All right, so you can see my screen.
Yeah, that looks great. Thank you.
Okay, should we get started or keep waiting?
Yeah, you can go ahead and get started. Thanks.
Okay, all right, so good morning. My name is Candace Hobson. I am an assistant professor, a neurotologist at Emory University. And this morning I'll be discussing Petrous apex lesions. The reason I chose this topic is that while these are relatively rare pathologies, we are consulted to see these patients either in our clinics or in the hospitals as inpatient consults. And the goal is so that when you guys do get these consults, you don't feel like a deer in the headlights, because that's how I often felt as a resident receiving one of these. So this lecture is mostly just a brief overview of Petrous apex lesions. So we'll talk about Petrous apex anatomy, the imaging basics, some common surgical approaches, and then also discuss commonly seen lesions. And again, they're rare lesions. The Petrous apex is the medial projection of the petrous portion of the temporal bone. The apex of the lesion is right at the clivus, so almost midline. You can think of the Petrous apex as having three surfaces. The anterior surface makes up the floor of the posterior portion of the middle cranial fossa. It abuts the greater wing of the sphenoid bone. The posterior surface is the anterolateral extent of the posterior cranial fossa. And then the inferior surface faces externally as the floor of the lateral skull base. The Petrous apex has anatomical relationships with most of the cranial nerves. Cranial nerve 5, trigeminal nerve, runs over the top surface of the Petrous apex and then leaves an impression on the anterolateral surface where Meckel's cave lives. Cranial nerve 6 runs over the superior medial surface of the Petrous apex before it enters Dorello's canal. The IAC runs right through the center of the Petrous apex, bisecting it or separating it into an anterior and posterior component or compartment. And then the jugular foramen lies at the junction of the Petrous apex and the occipital bone, so the junction between the posterior and the inferior surfaces of the Petrous apex. And then the nerves that exit the skull base through the jugular foramen are 9, 10, and 11. So again, the IAC splits the Petrous apex into an anterior and posterior compartment. The lateral boundary or extent of the Petrous apex is the fundus, or the lateral most extent of the internal auditory canal. And so the Petrous apex terminates that. It does not include the inner ear structures. The anterior compartment of the Petrous apex, which sits anterior to the IAC, contains the intrapetrous carotid artery, bone marrow, and then the fibrocartilage of the foramen lacerum. There can be variable pneumatization of the anterior compartment of the Petrous apex. The posterior compartment is more often pneumatized. In addition to containing air cells, also contains bone marrow. So again, there's variable pneumatization of the Petrous apex. Anywhere between 9 and 30% of patients have a pneumatized Petrous apex, and the posterior compartment is more likely to be pneumatized. The pneumatization is often asymmetric, and almost all Petrous apices contain some amount of bone marrow. When thinking about lesions of the Petrous apex or things that you may see, a simple way to classify these findings is separating them into 3 buckets: cystic lesions or findings, infectious pathology, and neoplasms. And we'll discuss most of these in the next hour. Petrous apex lesions are often found incidentally, and so it's unusual to have lesions that are symptomatic. When symptoms do occur, they're often related to the size, location, and nature of the etiology, the pathology. Common symptoms include hearing loss, dizziness or imbalance, headaches, which can either be retroorbital or temporal parietal in location, ringing or extra sounds in the ear, twitching of the face or facial weakness, paralysis, numbness of the face, double vision, or a draining ear. So in evaluating Petrous apex lesions, MRI and CT scanning can be complementary. Some key things to keep in mind when looking at imaging. For MRI, Marrow is T1 bright because of its high fat content, and effusions or fluid are typically T2 bright and T1 hypo intense. The CT scan is really useful in key in differentiating normal anatomy from pathology because it allows you to evaluate the bony detail and to determine whether there's bony expansion or erosion, destruction. Additionally, CT scan can be useful for following these lesions if you're choosing to observe. You can look closely at the lesion on CT scan and evaluate the lesion's proximity to critical structures, the carotid artery, otic capsule, the IAC, and that can help you to guide your management whether to continue observing or to intervene with a surgical procedure. So when thinking about surgery, there's 2 approaches or mindsets. So does the lesion need to be excised, which is typically the approach taken for solid lesions, malignant lesions, neoplasms, or is drainage enough to treat the lesion? And cystic lesions can often be managed with drainage alone. There's a number of approaches, and in deciding on an approach, it's really important to consider the nature of the lesion. Is it malignant? Is it worth being aggressive for? The location of the lesion, whether or not the patient has other medical comorbidities. And then finally, and probably the most important, what neurological deficits, if any, does the patient have from their Petrous apex lesion? Is there serviceable hearing or is the hearing completely out? Surgical approaches can be kind of split or divided into lateral and anterior approaches. The anterior approaches are what the anterior skull base surgeons usually employ, and then the lateral approaches are usually used by the neurologist. The most straightforward and least invasive lateral approach is a Transcanal-Infracochlear approach. This is done through the ear canal, but with a post-auricular incision. And the advantage to this approach is that it allows you to have gravity-dependent drainage of a lesion, and so useful for cystic lesions. In a similar fashion, you can perform a Transmastoid-Infralabyrinthine approach, and I have a couple of slides for these first 2 approaches. The infralabyrinthine approach is useful for lesions that are posterior in the Petrous apex, but may not be able to be performed in patients with a high writing jugular bulb, which can occur in about half of patients. If a patient has no functional hearing, a translabyrinthine approach can be utilized. And the advantage to this, of course, is that it provides you wider access and exposure to the Petrous apex. You get the widest access with a middle fossa approach, but a downside of this approach, especially for, or specifically for a cystic lesion, is that it does not provide gravity-dependent drainage. So this is an image illustrating the Transcanal-Infracochlear approach. Again, it's a post-auricular approach. You raise a tympanomeatal flap that is anteriorly or superiorly based. You drill away the floor of the IAC in order to provide yourself greater working room and wider exposure, more light. And then where you choose to drill is inferior to the cochlea. It's an infracochlear approach. You should be superior to the jugular bulb, and hopefully it's not high writing or even visible within the middle ear space. And you are posterior to the internal carotid artery. The Transmastoid-Infralabyrinthine approach, you're inferior to the labyrinth, and so you're inferior to the posterior semicircular canal, as you can see in the illustration. You are superior to the jugular bulb, so the success of this surgery really depends on the jugular bulb being low writing, and you're working posterior to the facial nerve, drilling until you access the Petrous apex and encounter the lesion. So common lesions that we'll discuss, we saw this on an earlier slide. Most lesions are cystic, with the cholesterol granuloma being the most common lesion. And we'll go through these now. We'll first start, however, with bone marrow. It's not a lesion, but something worth discussing and being aware of. You may receive a consult for an MRI finding with a hyperintensity on T1 imaging on an MRI. As you are evaluating this finding, useful images to review are the T1 fat suppressed MRI image. If it's bone marrow, on the fat suppressed image, it will no longer be T1 hyperintense. It's also not a contrast enhancing finding. When you look at the CT correlate, you'll see opacification of a pneumatized Petrous apex, but there will not be any bony expansion, destruction, or erosion. So the first actual lesion that we'll discuss, which is also the most common Petrous apex lesion, is a cholesterol granuloma. We call this a cystic lesion. It's a fluid-filled lesion, but it is not epithelial lined, and so it's not a true cyst. It's lined by a thick fibrous capsule instead of epithelium. The pathophysiologic etiology for cholesterol granulomas is, it's been debated. However, it's thought that there's bleeding in Petrous apex air cells, which could be from exposed bone marrow or from eustachian tube dysfunction, causing negative pressure and hemorrhage within the Petrous apex. But nonetheless, that blood is metabolized, cholesterol crystals form, and then there's a giant cell foreign body reaction, and this forms the cholesterol granuloma. These granulomas are typically seen in highly pneumatized Petrous apices without evidence of middle ear disease. The peak incidence for cholesterol granulomas, patients typically present at any age, but typically between the ages of 30 and 60 years old. Hearing loss is the most common presenting symptom. About half of patients present with complaints of hearing loss. That can be sensorineural from compression of the cochlear vestibular nerve. It can be conductive hearing loss if the cholesterol granuloma extends to involve the middle ear. Or sometimes it's coincidental, unrelated to the cholesterol granuloma and just an incidental finding. Patients may complain of dizziness, headaches, facial twitching, paresthesias, numbness. The imaging characteristics of cholesterol granuloma on CT scan, you see an expansile lesion of the Petrous apex with smooth margins in older lesions, or in newer lesions you may see scalloped bone. There's loss of the bony tuberculae or septations, and it's not typically contrast enhancing. However, early lesions may have enhancement of the capsule of the granuloma. The really key finding or distinctive finding of these lesions is on MRI. Cholesterol granulomas are both T1 and T2 hyperintense. There may be some heterogeneity of the intensity related to fibrosis, as well as the age of the lesion. So on this slide, we have both CT and MRI images of a cholesterol granuloma. The image on the left is a T1 MRI, and you see a hyperintense lesion that remains hyperintense on T2 imaging in the top right image. On CT scan, you see expansion of the Petrous apex bone. You don't see scalloping, you see a smooth kind of rounded lesion. And in the most anterior aspect of the Petrous apex, the bony margins are absent. These are additional images demonstrating a cholesterol granuloma from a paper in Otology Neurotology that was published this year. It looks similar to what we saw on the previous slide. The first image is a CT scan, and again, we see an expansile lesion with smooth bony margins of the Petrous apex on the right side. We see that on both T1 and T2 MRI imaging, the lesion is hyperintense or bright. The management of cholesterol granulomas, many of these lesions can be observed, especially if these are incidentally discovered asymptomatic lesions. We mentioned that patients may present with headache, but we don't know that the headache is the cause, that the cholesterol granuloma is the cause of the headache in these patients. So it's really important to consider and address other causes of headache and treat this first. Surgery should be considered for patients with progressive neurological symptoms, so the facial numbness, paresthesias, facial twitching, coarsening hearing, or if the CT scan demonstrates continued growth towards critical structures, the internal auditory canal or the otic capsule. The surgical approach can either be to drain or resect the lesion. Of course, resection decreases the risk of recurrence, but it's not always possible. Following drainage or resection, the cranial neuropathies may be improved or resolved. Headache, however, is less likely to resolve following surgery, and that's why we are hesitant or slow to offer drainage or resection of cholesterol granuloma for a symptom of headache alone. Cholesterol granulomas that recur tend to recur because of closure of the drainage pathway, and we really lower the risk of recurrence by completely excising the cholesterol granuloma. Another cystic lesion of the Petrous apex is Cholesteatoma. This represents anywhere between 4 and 9% of Petrous apex lesions. Cholesteatomas of the Petrous apex can be either acquired or congenital. When it's congenital, we call it an epidermoid of the Petrous apex. Acquired cholesteatomas are thought to be or known to be extension of middle ear or mastoid cholesteatomas. These are more likely to be complicated by infection. As we know, chronic or long-existing cholesteatoma may present as chronic suppurative otitis media. Congenital cholesteatomas, on the other hand, are less likely to be complicated by infection. These are sterile cysts. They occur secondary to developmental anomaly. There can be remnants from the first branchial cleft cyst, embryonic cells or displaced otic capsule cells within the petrous apex. And as a result, keratin debris slowly accumulates within the petrous apex, resulting in an expansile erosive lesion there within the petrous bone. On pathological exam under the microscope, acquired and congenital cholesteatomas look identical. The presentation of cholesterol granuloma can be a little different, whether it's congenital or acquired. Patients with acquired cholesteatoma of the petrous apex tend to have more advanced symptoms. And again, they're more likely to have the complication of overlying or underlying infection. But either way, in both cases, patients can present with hearing loss, facial numbness, paresthesias, weakness, dizziness, drainage in the case of acquired, and double vision. On CT imaging, cholesteatomas may appear as a non-enhancing lesion that's iso-intense to spinal fluid. There's erosion of the bone of the petrous apex that can be smooth or with scalloped edges. MRI cholesteatomas are T1 hypointense and T1 hyperintense. And if you see enhancement within the cholesteatoma, that suggests that there's a rest of squamous cell cholesteatoma, and your approach to treatment can be more aggressive. So in this slide, we again have CT and MRI imaging. The upper left image is a CT scan. You see erosion of the bone of the petrous apex. You can see some scalloping posteriorly within the apex. The bottom two images are MRI images of the cholesteatoma. You see an iso-intense image on, lesion on T1 imaging and a hyperintense lesion on T2 imaging. The cholesteatoma, unlike the cholesterol granuloma, is an epithelial-lined cyst, so drainage is not curative. Resection is ideal. Exteriorization can be performed, but this is difficult in the petrous apex. The approach depends on the size of the lesion, and then like all of the other petrous apex lesions, other neurological comorbidities, the presence or absence of functional hearing. The cholesteatoma matrix can really be very adherent to critical structures and cannot always be entirely removed. You have to be really careful as you remove the keratin debris within the cholesteatoma, because spillage of that debris into the subarachnoid space can result in a chemical meningitis. Another cystic or at least fluid lesion of the petrous apex is an effusion. This is also known as retained or trapped fluid. Typically an incidental finding seen in 1% of cranial MRIs. The petrous apex has to be pneumatized in order for an effusion to form. And it's thought to occur secondary to infection or fluid in the middle ear. That fluid extends into the petrous apex. However, because of mucosal edema within the petrous apex, that fluid becomes trapped. The symptoms of an effusion are similar to the symptoms of many other petrous apex lesions. On imaging, on CT scan, an effusion appears like an effusion. There's opacification of the air cells within the petrous apex, but there's no coalescence. All the bony septations are intact. On MRI, it also looks like an effusion. It's hyperintense on T1 imaging, and then either hypo or iso-intense on T1, and it's not an enhancing lesion. A mucocele is actually a cystic lesion. It occurs secondary to obstruction of a mucus-lined space. These typically occur in the paranasal sinuses and are really very rare in the Petrous apex. The symptoms and imaging findings of a mucocele are very similar to that as seen in an effusion. However, on CT scan for a mucocele, there is loss of bony septations. So basically it looks like an effusion, but the bony septations are gone. Again, typically not enhancing. The treatment for Petrous apex effusion or mucocele are very similar or the same. So asymptomatic cases you should observe with surveillance, so follow with CT imaging. For symptomatic lesions, the recommended treatment is a course of oral antibiotics and steroids. If symptoms persist or if the mucocele is expanding, you can offer the patient surgical drainage of the cyst or effusion. Keeping in mind that a craniotomy, so an intracranial approach, intradural approach to these tumors, or sorry, to these fluid collections risk intracranial contamination and possible meningitis if the contents of the mucocele are leaked. Petrous apicitis is something that I've never seen, but we're always tested on our board examinations. It's rare these days in the current era of antibiotics. The bacteriology for Petrous apicitis is similar to that for coalescent mastoiditis. These infections can be acute or chronic in nature. The typical triad of symptoms for acute Petrous apicitis includes retroorbital pain, diplopia with a cranial nerve 6 palsy, as well as a draining ear. And this triad is, I'm sure you guys all know, this triad is known as Gradenigo's or Gradenigo's syndrome. So the presentation, the pain can be temporal or occipital or classically retroorbital. The patients have symptoms of, and when you look in their ear, they do have otitis media, they have hearing loss, they've got a draining ear. On the same side, they have a cranial nerve 6 palsy, remembering that cranial nerve 6 runs over the anteromedial surface of the Petrous apex before it enters Dorello's canal. The complications of Petrous apicitis are the same as complications for acute otitis media. There's both intracranial, intertemporal, and extratemporal complications of this infection. On CT imaging, in a case of Petrous apicitis, you should expect to see an expansile erosive lesion of the Petrous apex with loss of the bony trabeculae. If there is an abscess, it can be rim enhancing, and that can be seen on either CT or MRI imaging. Additionally, on MRI imaging, this image is T1 hypointense and T2 hyperintense. The mainstay of treatment for Petrous apicitis is IV antibiotics, and additionally performing a myringotomy with or without tube, obtaining fluid for culture so that you may prescribe culture-directed antibiotics. In patients that have intracranial complications or who have progressive infection, non-resolution of infection despite medical management, surgical drainage should be offered. The approach depends on whether or not the patient has serviceable hearing, and also what other diseases in the mastoid, if there's Cholesteatoma in the mastoid, not that it all has to be addressed at the time of the acute infection, but a mastoidectomy should be performed. And from there, you can take an infralabyrinthine approach to the Petrous apex. Skull-base osteomyelitis, also known as malignant otitis externa, typically occurs secondary to extension of a bacterial infection from the ear canal. So otitis externa, malignant otitis externa. Pseudomonas is the typical pathogen, bacterial pathogen. You can perform CT or MRI imaging, but in early disease, it might not give you an answer. In advanced disease, especially on CT, you can see bony erosion, you can see bony sequestra, you can see demineralization throughout the Petrous apex, and also in the ear canal and mastoid. Nuclear medicine scanning can be useful in making the diagnosis. It's really important to note that for our technetium-99 study, while it does detect or make the diagnosis of osteomyelitis, the study remains positive even after resolution of the infection. So in order to follow for progression, or sorry, for resolution of the infection, a gallium scan is more useful. The treatment for skull-base osteomyelitis is culture-directed IV or oral antibiotics. Surgical management is typically reserved for patients with an abscess or with bony sequestra. Bony sequestra are just floating pieces of bone within the mastoid or within the Petrous apex. The reason that we perform surgery to remove these little pieces of bone is that they are loose and they're floating, and IV antibiotics aren't going to reach these little nituses of infection. On to solid or neoplastic processes of the Petrous apex. The first we'll discuss is the Chondrosarcoma. This is a really very rare malignancy. It accounts for about 1/3, however, of all primary bone malignancies in the entire body, but really not very common within the Petrous apex or intracranially. Chondrosarcomas arise from embryologic rest of cartilage at suture lines within the skull base. Most common site within the Petrous apex is just off the midline. Chondrosarcoma can arise from the foramen lacerum or the petroclival suture line. These are slow-growing tumors, and so as a result, the diagnosis is often delayed, and patients have advanced disease at presentation. Typical presenting symptoms for chondrosarcoma include headache, hearing loss, double vision, or a lower cranial neuropathy. And so that's different from many of the cystic lesions. Lower cranial neuropathies are much less common. On CT imaging of a chondrosarcoma, you'll see a contrast-enhancing lesion. You'll see significant bony destruction. And even within areas of bony destruction, there may be remnants of bone. You can see that here in the picture here on the right. There's little pieces of bone within the lesion. These calcifications are said to look like popcorn, and I think that's a convincing description. On MRI imaging, chondrosarcomas appear either iso or hypo-intense on T1 imaging. They're hyper-intense on T2 imaging. They're contrast-enhancing lesions, and as you can see in the T1 image, they are heterogeneously enhancing. Chondrosarcomas and chordomas can really appear very similar on MRI imaging. Chondrosarcomas are brighter typically than a chondrosarcoma, but the reality is that you're not typically comparing the two side to side in a patient. So the pathology helps to make the diagnosis, or does make the diagnosis. Surgical excision or resection is the recommended treatment for this malignancy. It can be difficult to achieve gross total resection of these lesions, secondary to the proximity to important neurovascular structures. Following resection, if there is disease left behind, stereotactic radiosurgery has been shown to be a benefit, resulting in over 95% 5-year control rates. Chordoma is another malignancy that can arise within the Petrous apex. This tumor arises from the notochord remnant, and so it's midline coming off of the clivus. It can occur anywhere along the notochord's development, so from the clivus all the way down to the sacrum. While this tumor arises in the midline, it can spread laterally to involve the Petrous apex, but it doesn't typically originate directly within the Petrous apex. Patients with chordomas are typically young. These tumors affect males more than females, but when females do have chordomas, they typically present at a younger age, and they're more likely to have a skull-based tumor than males are. The symptoms are similar to those for a chondrosarcoma, with headaches, double vision, and lower cranial neuropathies. Chordomas, again, are similar to chondrosarcomas on both CT and MRI imaging. You have a locally destructive lesion within the Petrous apex, but again, more likely to be centered along the clivus, not really shown in this picture, but more likely to be centered in the midline at the clivus than a chondrosarcoma. There can be retained calcifications of bone within the lesion. The lesions are T1 hypo or iso intense, T2 hyper intense, less bright than a chondrosarcoma. I'm not sure what I have in quotes here, but there can be a honeycomb pattern, and that's that heterogeneity in the contrast enhancement. Chordomas, unfortunately, are not very radiosensitive, and so it's really important to try to achieve gross total resection in these cases, but it doesn't often occur, and as a result, there's a relatively high rate of recurrence for chordoma following resection. Meningioma, you guys are probably much more familiar with. This is a benign neoplasm that arises from the dura. It accounts for 10 to 20% of all intracranial tumors. And when we see them at the Petrous apex, they're typically arising from the dura in the region of the petroclivosyncondrosis. Meningiomas have a very characteristic appearance. On CT scan, they're iso or hyperintense lesions, sometimes with intralesional calcifications. They're, of course, contrast enhancing, and you can see hyperostosis of the adjacent bones. So in the case of a meningioma at the Petrous apex, the hyperostosis would be at the posterior surface of the Petrous apex, or that posterior face. On MRI, these lesions are T1 and 2, typically hyperintense. They are contrast enhancing, and they've got a broad base with a broad dural enhancement. And then the dural tail is really your key to identifying this as a meningioma. So the management or treatment of meningiomas, observation is always an option for a meningioma in any location. The decision to treat depends, of course, on the size of the location of the tumor, whether it's growing or not, and what morbidity it's causing the patient. The approach depends on the location. The goal is gross total resection, but not at the cost of additional morbidity or injury to critical neurovascular structures. So if there is residual disease following resection, patients should be offered stereotactic radiosurgery. The last thing I think that we'll discuss are metastatic lesions. Metastatic lesions can occur anywhere within the intracranial space, but they can affect the Petrous apex as well. The most common tumors that may metastasize to the Petrous apex in descending order are the breast, lung, prostate, melanoma, and the kidneys. Metastatic lesions can occur, of course, at any age, but occurs most commonly in patients in their 50s to 70s. The most common route of spread or way of spread is hematogenous for distant tumors or for leukemia. The thought is that the slow blood flow through the marrow spaces within the Petrous apex results in filtering and deposition of tumor cells within the bone marrow space there in the Petrous apex. Mets can also occur via direct extension from an extra or intracranial neoplasms or leptomeningeal extension from distant sites within the intracranial space. Within the temporal bone, the Petrous apex is the most common site for metastasis. And typically when there are metastases within the Petrous apex, there's also metastases other places in the body, most commonly in the lung or within the GI tract. The imaging characteristics of METs really depends on the primary tumor, but in general, these are contrast enhancing locally destructive lesions. And so lastly, I have a table summarizing some of the common Petrous apex lesions. I think this is useful to have handy somewhere when you do receive a consult or see a patient for a Petrous apex lesion. It's a nice quick reference to kind of guide you as to how aggressive you should be. Should you observe this patient? Should you get a CT scan or an MRI in 6 to 12 months? But it's really important to have both modalities of imaging. It's difficult to make a diagnosis with MRI or CT scan alone. So generally the next step when you see a patient with a finding of a Petrous apex something is to get another imaging. If they had a CT, ask for an MRI. If they've had an MRI, ask for the CT. And that's it. Are there any questions? Asymmetric, yeah, sure. Where did my... Oh. Sorry, lost my screen share. Trying to get back to that. Okay, so can I go back to review the use of fat-suppressed MRI to help identify asymmetric pneumatization in bone marrow? And so bone marrow has a high fat content, and so we expect it to be bright on T1 imaging. However, if you get a fat suppressed, or if you have it there, so if you choose to look at the fat suppressed T1 MRI image, the bone marrow should no longer appear T1 bright. The second question, have I ever ordered a technetium or gallium scan for osteomyelitis? I've ordered it once as a fellow at Kaiser because it was easy to get approval for almost any imaging study that we ordered. It's harder really anywhere else. We've asked for it and never gotten it. And so often what we end up obtaining is a CT scan. The downside, of course, is for a CT scan to show bony erosion. In the case of MOE, the disease has to be pretty advanced. Other useful, I guess, objective data that you can use to help make the diagnosis of MOE is a white blood cell count, ESR, and CRP. And many physicians will use an ESR to track the progression of the disease in response to antibiotics. So watching the ESR fall to a normal level. Are there other questions? Okay, so I think that is it then. Thank you everybody for listening.